Welcome one and all. On Tuesdays, most Tuesdays that we're in session, Senate Democrats and Senate Republicans eat lunch, never together, always apart, and talk about the challenges that we face as a nation. And we spent the last hour and a half in the Senate Democratic Caucus talking about the budgetary challenges that we face and what to do about them. And one of the people who's thought about this for a lot longer than this week or this month or this year is a fellow who's sitting to my right, Dr. Coburn, who's just joined us. He was a member of a commission created by executive order by the President over a year ago called the Deficit Commission, co-chaired by Erskine Bowles and by Alan Simpson, former Senator Alan Simpson. And 11 of the 18 members of that commission voted for a deficit reduction package that would basically reduce the deficits by about $4 trillion over the next 10 years, mostly on the spending side, some on the revenue side. And it was an approach in which almost everything was on the table: defense spending, domestic discretionary spending, entitlement spending, tax expenditures, and weighted about 2 to 1 or 3 to 1 to the spending side in terms of deficit reduction. One of the concerns primarily among Democrats, but also by Republicans and some independents, is how do we reduce entitlement spending without significantly cutting benefits and inflicting real harm on people? Thanks to the good work by folks on my staff and on Senator Coburn's staff, some good work has been done, drilling down on Medicare and on Medicaid to find are there ways for us to be able to reduce outlays from those programs, but to do so in a way that does not mortally wound beneficiaries, or frankly, mortally wound the providers. As it turns out, there's a lot that we can do, and there's a fair amount that we're doing. The healthcare legislation that we passed here a year or so ago actually provides a number of tools to CMS to enable them to go out and save some money and to reduce the flight of funds, almost the thievery of funds, the theft of funds from the Medicare Trust Fund. And Senator Coburn and I have been working, our staffs and I have been we've been working, and to see if there are other things that we can do to shore up the Medicare Trust Fund, which is now scheduled to run out of money in 2024. As it turns out, there's a fair amount that we can do, and in our role to help some of you at this table, especially Dr. Budgetary and his folks, to realize additional savings. And a lot of us would just say it's common sense. A fellow who just handed me my talking points here is Peter Tyler. Peter's done great work here with our Republican staff. But one of the things that we learned most recently was that in 2007, if you look at the amount of money that was spent, what was the expenditure, Peter? What was it for 2007? About half of it was wheelchairs. That's what it was about. It was wheelchairs. And I don't know if this came from the IG or from GAO or who. Who did it come from? The IG? Yeah, the IG. 2007, we spent I think about $190 million for wheelchairs that year. And roughly half of that was, frankly, pretty hard to prove. It should have been spent. We have dead doctors writing prescriptions for controlled substances. For folks who shouldn't be receiving those substances, they're going out and filling those prescriptions and using the drugs to help feed the drug trade. It's far too easy for bad people, folks with criminal intent, to get their hands on the provider IDs, and they're not only ordering controlled substances, but all kinds of durable medical equipment. There's just a lot going on. You look at improper payments, $125 billion, I think GAO tells us last year, about $47 billion of that for Medicare. Medicare, not counting Medicare prescription drug program. I'm told there's about another 20 or so billion last year for Medicaid improper payments. Eric Holder, our Attorney General, tells us there's $60 billion in Medicare fraud. I don't know if he's combining and pulling some of those numbers out of improper payments or not, but it's a lot of money. And if the president says we're going to cut the improper payments in Medicare by half by the end of next year, if we do that, that's $25 billion a year. Do it for 10 years, that's $250 billion. That's a quarter of a trillion. If we take out half of the fraud in Medicare, that's another $30 billion a year times 10 years is $300 billion. And you add it together, we're talking about real money. And none of that has to savage beneficiaries or inconvenience providers. We're interested in getting better results for less money. And we've been interested in that in healthcare. We're interested in a lot of other ways. And one of the ways to do that is to frankly, drill down on some of the stuff we're going to talk about today. And I'm just very grateful to each of the witnesses for coming, for preparing for today's hearing. Let me start, if I could, with Dr. Budgetary. And I think first I'd like to address an issue that's been raised by GAO. First, before I do that, I just want to say, Dr. Budgetary, that the Office of Program Integrity under your leadership has made, I think, a lot of progress. And there are a number of people that are responsible for that. But I just want to say to you, thank you. Since you took your position last year, there have been any number of positive efforts underway, including the implementation of program integrity provisions within the Affordable Care Act. I think you deserve a lot of credit. So does your team, as does the program, as do many of your colleagues at the Center for Medicare and Medicaid Services. However, as I say oftentimes in this room, everything I do, I know I can do better. The same is true for all of us. And the enormous waste and fraud challenges that we have, that we've heard about again here today, and we've heard about in the past, and hopefully we'll hear about in smaller magnitudes in the future. But those challenges call out for very large efforts and require that the Congress ensures that the federal government takes many more strides to cut back on waste and fraud and abuse where we can. Now, in the GAO testimony and their audit report released today, the fraud detection systems, that is the combined integrated data repository and one PI, is presented as an important new tool to examine Medicare and Medicaid payments in order to detect fraud. And it's depicted on this chart up to my left and to your right. In fact, the Centers for Medicare and Medicaid Services own estimates show that if it's fully implemented, the new fraud detection systems will save some $21 billion over 10 years by detecting and avoiding improper payments. The cost to date for the system is about $161 million. And to complete and operate the system for 10 years, the additional cost is roughly $184 million. That is quite a return on investments if you think about it. And curbing $21 billion in waste and fraud would represent a lot of progress, a lot more progress. I think it makes sense that a timely implementation would help get these cost savings, obtain these cost savings more rapidly. It's what we want to do. However, the GAO has clearly shown that the system is not fully deployed. Despite the Center for Medicare and Medicaid Services declaring the system up and running, only, as we've heard, 42 people were trained in 2010. And despite the stated requirement for, I think, 639 people. Further, the system has yet to include Medicaid data. Also, GAO reported that there are no clear plans nor projected dates with specific milestones to either train more people nor to include the Medicaid data. And despite being part of the original design, there are no solid plans to give access to Medicaid state offices, I'm told. Obviously, without the system being fully implemented, as well as ensuring that federal staff, oversight contractors, and law enforcement have access and are fully engaged, we won't realize that $21 billion in savings, and that would be a shame. So, Dr. Budgetary, let me just ask, what is your planned schedule to fully implement and deploy the new fraud detection system? When will we have more people trained, and when will state Medicaid offices have access to this system?
Thank you very much for your comments, Senator. And I want to add that we always welcome the kind of arm's length oversight that we receive from the General Accounting Office, the Government Accountability Office, dated myself there, and from our colleagues at the Office of Inspector General. And as you know, in this case, we do in fact concur with their recommendations.
Can I just make a comment?
Sir.
I say this a lot. We're all in this together.
Yes.
We're all in this together. And the only way for us to get out of this hole, this fiscal hole that we're in, including some that we're talking about here, is to get out together. Go ahead.
And we very much appreciate the interest and support you've shown in this, sir. The integrated data repository and the One PI system are ones that were started some 5 years ago or so. The agency did set rather ambitious goals for itself in terms of the implementation of those. And some of those goals have been met, some of them haven't been met. This illustrates a number of factors. First of all, it does illustrate to some degree the challenges of implementing systems, especially, for example, with respect to the Medicaid data, because states have different kinds of data systems and different formats and different responsibilities on the states in terms of their ability to supply the data. The structure of the integrated data repository at first had to be, as I understand it, had to be redone somewhat. So there were some problems along the line in terms of meeting certain deadlines. Others were met. But in terms of your specific questions, I'd like to make a couple of points, sir. One is that the integrated data repository is intended for many purposes other than just fighting fraud. It is a valuable resource. And it continues to be a valuable resource, and it will be as we move forward with our new and advanced technological solutions that I mentioned earlier. But the integrated data repository is not strictly for that purpose. It also has a variety of other uses within CMS, and that's an important aspect of this. The other, I think, question that you asked about the training, we have in fact now trained an additional 55 personnel so far this year. We now have a schedule for training all of the private sector personnel who are going to be working with the One PI and integrated data repository.
Give us some idea what that schedule is. That would be 42 plus about 50. It's about 100.
They will all of the ones who are in the, I don't know the exact number, but it's all the ones who are in our zone program integrity contractors, the anti-fraud contractors, who will be using the system. I'm told that they are all on schedule to be trained this year. And so that's, we did have to, after getting feedback from the people who were trained in the initial courses, we did redesign the program. We had some user feedback and realized that we weren't, the agency wasn't adequately preparing them for using the system. These are complicated systems, and the training program was restructured and revised, and we believe it's now an extremely effective one. And we have moved forward with an aggressive schedule. We've trained 55, and we're going to finish the ZPIC staff training, I'm told, this year. So that's a very important aspect of all of this. The other thing I would tell you is that the integrated data repository will be one of the sources of data that we will be using in the sandbox that I described, so that the integrated data repository, which holds all of the claims over a prolonged period of time, is very different than the claims processing system that we're using with our new predictive analytics. So one is a repository, and the IDR is a repository that will hold all of the information. The other is being implemented on top of the claims processing system. So they will go hand in glove. We are moving forward. We anticipate having, we already have the Medicare claims data in, as you described. We anticipate finishing the different stages of the Medicare data by next year. And we are moving very aggressively with a variety of systems to improve the Medicaid data as well. And doing that in a way that we believe will serve a variety of purposes, both for the states and providing access to the states, and also for our purposes, both fraud fighting and otherwise.
Okay, I'm going to ask you to hold there. I'm well over my time, so okay. I want to be fair to my colleagues. When we come back, I'm going to ask our friend from GAO just to respond to what we just heard from Dr. Budgetary, and you can tell us whether or not we should feel reassured. Don't do it now, but I'm going to ask you to tell us if we should feel reassured by what he has just presented. All right, thanks.
Senator.